We'll eventually post all these sessions on our website.
It is recording, so.
Thank you, sir.
All right, sweet. So we'll go ahead and get started. For those who haven't met, I'm Hamza, as Mike was saying, one of the fellows in GIM here at Western. So this is my second block of ultrasound, and I find this is a really interesting area for me personally. Specifically thinking about like how we can kind of incorporate ultrasound more into the GIM world, whether that be on the wards or the clinic. So I thought this was an interesting area and I wanted to do my presentation on. And it was a great blog. I got a chance to do lots of VExUS studies. So, all right, let me see if I can get the slides going here. I guess I got to click. And can you guys see my mouse? Because I'm going to be using that a little bit. Yeah, perfect. Aaron's nodding.
Yep.
So I don't have any disclosures beside of personal interest, as I was mentioning. I do want to give some, where are the slides not moving? There we go. Okay. A few thank yous, first of all, to Mike and Zane for just being great mentors and helping me get a lot of scans and teaching me how to, be better at getting the scans. And special thanks to Aaron as well, like for letting me borrow a few of his scans and a couple of the cases as well. So thanks a lot to Aaron. And I'll try to point out who did which scan. So if you guys aren't happy with it, you know who to blame. Okay, so we'll talk a little bit about, where VExUS came from and its role in the literature in the cardiorenal population. We'll talk a little bit about how to perform VExUS. It won't be a comprehensive sort of overview, but I'll try my best here and give a few tips and tricks after doing many studies myself. And then we'll apply it to a few cases. And after that, hopefully open up to some questions and discussion. First of all, though, I'm going to give you a bit of a case teaser, and we'll come back to this after, but just to kind of give you guys some context as to how we're going to be applying this concept. So we have a 55-year-old gentleman, Mr. CR, who's been admitted to the Parkwood rehab for a little bit. He's had some poor functioning related to a prior stroke. He's known for HFpEF, hypertension, and CKD with a baseline creatinine of 150. So at Parkwood, my apologies, my voice is been a little bit unwell. So he's been on Lasix 40 for some time. And this is for some edema. The staff there have noticed his edema has been a little bit worse. So what they did is they, pretty reasonably doubled his Lasix to 80 twice a day. When that wasn't working, they switched to IV Lasix, and they got some blood work done a couple of days after, and they found that the creatinine actually bumped from 170 to 313 in 2 days, and he actually has decreased urine output at that time. They sent him to the ED here. POCUS is done in the ED department. They feel the patient is dry. There's no B lines that they can see. There's maybe some small bilateral effusions, but there's no hydro. The IVC they feel is indeterminate. And so their conclusion is this patient probably has a pre-renal AKI from overdiuresis, given the recent increase in his Lasix, and they give him some IV fluids. The next day, the creatinine is now 305, so maybe a little bit better than the initial. And the JMR on the team says, well, it's perfect. Like, we just got to give him a little bit more IV fluids. It totally fits the pattern here. So I'm going to leave it at that for now and give you guys something to think about as we move on to some of the other parts. Mike's already kind of like thinking about all the things he would want to say to the junior. Okay, this next part is a little bit dry, and I do apologize about that. But bear with me here. We'll get to some fun stuff after. So this is the origins of VExUS, where it sort of came from and what the current landscape is in the literature. This is the first study that sort of looking at venous congestion as a marker for AKI. It's a study by Beaubien Solinier et al. And his colleagues from the University of Montreal. And they essentially took 145 patients there, post-cardiac surgery in the surgical ICU. They essentially did serial portal and renal Dopplers for 3 days on these patients. And they essentially found that there was a correlation between portal flow pulsatility as well as intrarenal venous flow alterations, with hazards ratios of 2.09 and 2.81 respectively, in terms of correlation to an AKI. And so this really was the initial impetus to see that there actually may be a signal here. The next sort of big paper, sorry, this is skipping slides for some reason. I think it's when I click it. My apologies, technical issues. So this is a slide we were on. So this was really the impetus, and the next thing they wanted to do was actually figure out how to actually put this into practice. I don't know why it's doing that. Sometimes it's not moving slides and sometimes it's going 2 slides ahead. Okay, here we go. This is the next slide. Sorry about that, guys. So essentially what they did is the same sort of group of authors in 2020. They did a post-hoc analysis looking at different prototypes on the various vessels they examined. And they essentially came up with one prototype that had the highest hazards ratio of being correlated with an AKI. And it's sort of the way we typically grade VExUS scores today. And we'll go into this a little bit more further, but this is sort of how this scheme and this grading score originated from. Okay, this next paper is really what got me interested in this being used in the cardiorenal population. This was an Indian study done by Bhardwaj et al. In 2020 in the medical ICU. They took patients coming in with a provisional diagnosis of cardiorenal, and they looked at the IVC, the hepatic vein, and the portal vein. They graded a little bit differently in that previous study, but regardless, they looked at 30 patients and they saw a resolution of AKI correlated with improvement in the VExUS grade. And interestingly, there was no correlation between the VExUS grade and the CDP, the LV function, or the RV function. So this is a graph from their paper, and it sort of is self-explanatory here. As your AKI improves, the VExUS score improves. As the fluid balance decreases, the VExUS score also improves or comes down. So, and they were essentially, this is a proof of concept showing that as the VExUS grade improves, it is a sign that there is clinically significant decongestion also going on. Taking this a step even further, these 3 authors in 2021 looked at, well, can we just look at the portal vein, for example? Now, mind you, they had a very small patient population of 12 people here, but they just essentially took acute CHF patients and they just looked at the portal vein Doppler. And they found that the pulsatility fraction, and here the higher that is, the worse congestion you have, improved significantly after effective decongestion. Another interesting finding that they had is the IVC size and collapsibility changed with left-sided heart failure patients, but did not change in right-sided patients. So I really like this graph here. They essentially have all 12 of their patients here before and after decongestion. As you can see, like these portal flows are really, these are in the severe category, greater than 50%. One patient even had flow reversal, it looked like, and they really smooth out after decongestion.
Sorry, Hamza, do you mean portal or hepatic? Like you mean portal, right?
This is portal. This is portal. I'm sorry if I said hepatic here. Yeah,
okay,
these are portal flows. And this is, as you get decongested, your portal pulsatility is coming down quite nicely. Graph on the right here is essentially showing in your patients looking at the IVC itself. Maybe be helpful in left-sided patients, but patients with right-sided failure, there was really no change in the IVC, even though they improved clinically and their portal vein pulsatility had come down. And so where do we sort of stand today? Well, it's being VExUS is being implemented even more so. This is a recent paper by a team of nephrologists that essentially looked at when we have an AKI, we can actually do so much with the ultrasound, looking at the heart, the lungs, the kidneys themselves, but also now incorporating this idea of looking at the venous Doppler system. Okay, so that's sort of where we stand, and this is sort of how we got here. But how do we actually perform VExUS? Okay, so I've taken this akin to looking at the 4 great vessels of VExUS, the 4 great houses of Hogwarts. Sorry if this reference doesn't land for everybody, but hopefully y'all will follow with me a little bit. So what's the first thing we want to look at? Well, it's the IVC, and I think this really is the mainstay of Slytherin House here. It really is a great big dirty snake after all. And it's very sneaky, right? You want to be very careful about measuring the IVC, ideally with a nice short axis view, but also in the long axis, there's a lot of pitfalls here that, I won't get into, but a couple of things to note there. The next house is Ravenclaw house, and I think the hepatic vein has to go there. Why, you may ask? Well, when you put Doppler on, you get a nice blue waveform there. The third is the portal vein, which is really identified by its nice thicker walls that are hyperechoic on ultrasound. And why is it a Gryffindor? Well, because as you'd imagine, when you put Doppler on, it comes out nice and red like that. And then finally, you have the renal veins, who I kind of got to put in Hufflepuff, simply for the fact that sometimes it goes a little bit unnoticed. It's a tricky scan to get the renal vein, and so sometimes we aren't able to do it. And so, it takes a bit of a backseat, unfortunately. Okay, so I actually had to replace a lot of these images here because of Mike's recent scan done yesterday that I'm going to hopefully showcase for this part. It's kind of some classic severe VExUS here. Okay, so these are the 4 vessels, the 4 great houses we have to think about. How do we actually go about assessing them? So starting with the IVC, we first want to see if we can identify the IVC. We want to get a nice measurement here. So this is a pretty plethoric IVC and it's measured at 2.3 centimeters. That's the first step of our VExUS study. For IVC is actually smaller than 2 centimeters. We can stop right here because the likelihood of venous congestion down the road is essentially none. But if our IVC is greater than 2 centimeters, then we can go ahead and move forward with the study. The next step is to look at the hepatic vein. This is the IVC, and you can see the hepatic vein coming to the top here. We put a little bit of color on that, and this is from Mike's recent study. You can see there's, and you might have said, well, Hamza, you just said, hepatic veins are Ravenclaw. Why are we getting so much red here? And that probably is related to the severity of the venous congestion in here, where we might see flow reversal, and that comes up as red. So I did want to show, this is a different patient here in the bottom, and this is more of a classic picture. What we'd see is really just that nice blue on the Doppler signal. And the final step of the VExUS, when we're interrogating these vessels, is to then put pulse wave Doppler and get a nice signal. So that's what Mike's done here, and he's gotten a really nice sort of flow reversal pattern. So how do we grade each vessel? So for the hepatic vein, we're looking at the S and D waves, S correlating with systole and D with diastole. Normally, our systolic vein is greater than diastole. As we get more and more towards abnormal, we'll initially start to see the D wave get larger than the S wave. And then finally, we actually see S wave reversal here. These are pictures obtained from POCUS 101 that have a really nice article on this. Okay, now moving towards the portal vein. This is not from Mike's study. I just wanted to keep this image in because it really highlights, again, that hyperechoic kind of border of the portal vein. That's really what's classic to identifying it. Now, this is back to Mike's study. He found his portal vein that looks a little bit different here, but again, that hyperechoic structure. Puts color on there, and then he does get a nice sort of red flow there. He puts his pulse wave Doppler on top, and then he's getting a nice waveform here with a lot of scalloping, which is, when we look at the signals, is in keeping with severe abnormality. So what is a normal portal vein signal? We should see a nice smooth portal vein. As it starts to become a little bit more pulsatile, we call that mildly abnormal. And then when it's really scalloped, that's severe. The way we calculate pulsatility index is the maximum velocity subtracted the minimum velocity and dividing that by the maximum velocity again. Okay, and then finally the renal vein, which is, again, a lot of, it's just a trickier scan. But here Mike's done a great job of isolating the kidney, putting some color there and finding a little bit of a signal, putting the Doppler, and then getting just a great wave pattern here that's a lot of times very difficult to find. So the renal vein Doppler really is, it's what we're worried about is the bottom part. The top part is typically a renal artery that we're catching as well. Similar to the portal, we should expect nice continuous monophasic flow. With a mild abnormality, you're going to see a discontinuous flow. And then when it's really severe, you're going to lose that S wave component altogether. And so this is sort of the summary slide that I think is just a great resource. It goes through the steps of the VExUS system, goes over the various waveforms, and finally, how do we actually grade VExUS? So grade 0 is an IVC that's nice and flat. Grade 1 would be a plethoric IVC, but no severe abnormalities in the other vessels. One severe abnormality buys you a grade 2, and then a grade 2 VExUS score means you have 2 severe abnormalities. Okay, so now that you're sorted into these 4 great vessels, how do you actually integrate VExUS into your study? And I think this is something I wanted to spend a little bit of time on. And I think there's kind of two ways to do this. It can be an extension of your cardiac study or an extension of your thoracic study. So starting off with your cardiac, let's say, you're doing your ultrasound on a patient, you're looking at the patient's heart here. For doing our parasternal views, we go to our apical views. And then when you come to our subcostal views, a lot of times you can get really good images of the IVC and hepatic here. For example, this is a subcostal done with the phased array probe in the cardiac setting, and we're getting a hepatic vein here, as you can see, going blue here, and it's pointing straight at us, getting us a really good Doppler angle. Now, let's say, for example, if we aren't able to get good images here, I recommend at this time then to switch to the abdominal probe that has better penetration. We can stay in the subcostal area to see if we can get better images here. But again, if we're not able to, then going to the right upper quadrant really is the better option. These are images captured there, and as you can see, you can really get a great portal here. And this is where we also go on to find our renal vein. Now, let's say you're doing a thoracic study. You start with the left side of the lungs, you move on to the right side, and then as you're in your costal space, this first image here, I think, does a great job of, if you just sort of rock the probe a little bit south of the diaphragm, you a lot of times can see the liver, and you can see this here, for example, a nice IVC and hepatic vein here. You can put some color on there and we have great Doppler signal. So a lot of times that's another way we can kind of integrate our VExUS study. Let's say, for example, we can't get good images. While you're already in that spot, it's a great time to just switch to our abdominal probe and get images that way. And then you may want to come back to the subcostal area with that same probe to find the IVC if for some reason you weren't able to find it in the right upper area. Okay. Some general tips and tricks that I sort of picked up throughout my time was making sure that, first of all, your Nyquist limit is turned down to about 15 or 20. You want to make sure you adjust your scale when you do capture waveform. The default of about 50 and -50 is typically too large, or portal vein Doppler is going to be very small and minute, so increase or decreasing that scale will help the waveform stand out. Considering ECG gating, so this is something, to be honest, I did not do a lot of ultimately in my time, but certainly for the hepatic vein, it'd be a good idea to consider that. In retrospect, there are a couple of studies that probably would have benefited from that. Taking time to optimize the Doppler angle, I think that's a really important thing as well. Making sure that the vein is pointing towards us as best as possible to get a nice direct Doppler angle is key. Being aware of the pitfalls, knowing that TR can cause a false positive on our hepatic waveform, for example. Knowing that cirrhosis and portal hypertension can cause false positives or false negatives, in our portal waveform. Things like that are quite important. But I think the biggest tip I would have to give is finding patients that are able to hold their breath to avoid respiratory variation. I think this is a huge one in really optimizing our images here. Okay. So we've gone through the literature, we've kind of gone through how to actually do VExUS. Now let's actually apply it to some cases. I've done my best to kind of pick out some cases where I thought VExUS was more key in terms of being the step in clinical decision-making, but there are certainly some caveats, as you'll see. So going back to our first case with Mr. CR, to remind you guys, this is a patient that was having worsening edema, had increased Lasix dosing, and then had a creatinine bump from 170 to 313. The team thought they had a prerenal AKI, and the junior wanted to give him more fluids. So let's try some VExUS first. Let's see if we can actually get a sense of what their venous congestion is like. And so as we do our ultrasound, we can see here that he has a fairly plethoric IVC, and there's not a lot of movement with respiration here. And a measurement here leaves us 2 centimeters, just on the cusp, but enough for us to then go ahead with the rest of the study. Dilated IVC. And so these are all his waveforms. So we'll go through them one by one. So with his hepatic waveform here, we can see that his S wave is smaller than his D wave, which is considered mildly abnormal. His portal vein here, as we can see, has that nice classical scalloping with a pulsatility index of 56%, keeping with severely abnormal. And his renal vein here is discontinuous, and it's biphasic, and this is in keeping with mildly abnormal. I believe these are the courtesy of Aaron doing some great scans here. So all in all, this patient kind of got a VExUS grade 2. The decision was made to aggressively diurese this patient with IV Lasix, and he overall improved slowly, as well as his clinical symptoms of edema. So I think that's a really nice classic case where a patient came in, they thought he had a prerenal AKI, and the ultrasound helped convince us that, you know what, actually, this probably is just ongoing venous congestion and he needs more aggressive diuresis. Okay, so go on to our next case here. This is Mr. HF. He's an 80-year-old guy coming in with dyspnea and weakness and some kind of non-specific symptoms. He does have a history of stage 5 CKD, the baseline creatinine of 250. He has a history of HFmef with diastolic dysfunction and a normal RV, and some other cardiac and other medical issues. So he actually had a recent admission to the hospital 4 days prior with a CHF exacerbation. And they sent him home on a Lasix dose of 120 twice a day. But there was a bit of a concern about medication compliance from home. In hospital this time, he's on room air. He has a bit of peripheral edema, but not much to write home about in the lung. He's got no crackles. His chest x-ray looks pretty unremarkable, but certainly a bit of a bump in his creatinine here. It went from 250 to 386. The team actually, given the medication non-compliance, started him on Lasix 120 milligrams IV twice a day. 3 days later, his creatinine comes back at 414, so actually a little bit higher than it was before. And not unreasonable at this point to think, well, you know, are we actually on the wrong path here? Could it be very intravascularly deplete? Are we actually making things worse with this aggressive diuresis? So another role for ultrasound and VExUS. So just wanted to kind of quickly show his heart scans here. Similar to what that echo had shown for him, his HFmef, he's got a little bit of reduced ejection fraction here, probably, or systolic function. The RV looks, you know, reasonably pretty crisp, is moving quite well, doesn't look particularly dilated. He might have some regional wall motion abnormalities, but and now let's move towards his VExUS. So his IVC, as you can see here, looks quite plethoric and measured as 2.37 centimeters. And I believe this are also just great images by Dr. Leung, showing his hepatic vein here, that lighting up like a Christmas tree, and you're getting all you can see already is blue and red here. And on the Doppler image, you're getting S-wave reversal here. So this is in keeping with severe abnormality and signs of congestion. Now, unfortunately, this gentleman was a little bit, got quite frustrated at this time, so we were unable to get sort of his portal or renal vein Dopplers. But even with this information, we were able to give him a VExUS grade of 2, and we can feel a lot more confident about being more aggressive with diuresis. So the team at this point switched him to IV Lasix infusion and metolazone. He had a comprehensive cardiology-led bubble echo done that showed, you know, kind of confirmed the POCUS findings, and also showed he had a patent PFO. After aggressive diuresis, the creatinine finally improved in addition to clinical symptoms, and he was able to be switched to a stable diuretic dose. This is his trend of his creatinine. I thought this was actually really interesting. He comes in at 380 or so, right? The team starts him on 120 IV Lasix, and creatinine continues to rise despite that aggressive diuresis. It was around this time where you get switched to, you know, an IV Lasix infusion and metolazone, and still his creatinine starts to rise until finally that level of decongestion where it, like, you know, falls off, and then his creatinine does finally improve. I think it's a nice showcase to show that sometimes the creatinine is not the most dynamic marker of cardiorenal syndrome or how well we're diuresing a patient. Okay, this is our final case. This is Mrs. OD. She is a 65-year-old lady admitted with worsening hypoxemia and weakness. This is a lady who had recent COVID, unfortunately with some post-inflammatory issues, and she's on a bit of home oxygen. She also has CKD with a baseline creatinine about 150. is quite a large lady, which makes physical examination quite difficult in her case. On initial presentation to the ED, her creatinine was noted to be 217. She was actually given IV fluids overnight, and her creatinine did improve a little bit. And the morning team was pretty astute here. They felt right away that she actually looked to be in volume overload on her exam, even though it was a bit of a tricky exam. They right off the bat questioned, could she have cardiorenal syndrome from venous congestion? And they started her on IV Lasix and stopped the fluids. Started her on a, on the lower end of the spectrum of doses with 40 IV daily. 2 days later, creatinine is more or less unchanged at 214. An echo is done, which reports that she actually has a dilated RV, moderately reduced function, and notably severe TR. The team at this point, given the creatinine not really budging, requested a POCUS to help with her volume status. Okay, so jumping into her IVC study here, as you can see, it looks quite plethoric. Unfortunately, a measurement was not taken at this time. Now, looking at her hepatic vein, she appears to have S-wave reversibility here, which is keeping with severe abnormality. The caveat I do want to point out is because she has severe TR, she is very likely to have hepatic vein reversibility here. So we have to sort of take that with a grain of salt.
Sorry to interrupt, Hamza. Just for the sake of teaching, could you just point out to us where the reversal of the S wave is?
Yeah, for sure. So we would say, based on this, this would be her S wave here, and this is probably her D wave here. Doctor, you make a great point. Like if you had ECG gating to kind of show that this is where her QRSs are lining up with every S wave, that would be fantastic. And so with the hepatic vein, as we sort of mentioned before, ECG gating would be really helpful.
Yeah, certainly. So, yeah, I guess, that's exactly, I think, your point made previously. It's really hard to interpret the hepatic vein sometimes when there's different reversal and different loading factors without an ECG to help guide you.
Yeah, certainly. Looking at her portal vein, she had what was considered a mildly abnormal portal vein Doppler here. And again, I want to point out here, like the scale, again, is too high. So we're not really seeing that waveform as well as we could. Unfortunately, we weren't able to visualize her renal vein. Okay, so with those findings, she was a VExUS of grade 2. It was felt that she probably has cardiorenal in the setting of RV dysfunction, and her diuresis was increased at this time to 40 IV BID to see if that would help her. A couple of days later, her creatinine, it improved initially from 209 to 187, but then again plateaus. Now, this is an interesting part of this case, I thought, is that another ultrasound was done at this time with a VExUS looking at her portal vein. And as you can see, it looks a lot more scalloped than the study done a few days earlier. And if you to her pulsatility index now is 56%, in the range of severely abnormal and probably, worse than it was before. Keep that in the back of your minds. Ultimately, she continues on diuresis. Her creatinine improves a little bit more to 178, and she's ultimately discharged home on a higher Lasix dose than what she came in with. She comes back to the hospital 2 days later. Post-discharge, her creatinine is now 312, a lot higher than the 178 it was a few days previously. The admitting team actually feel that maybe she has a pre-renal AKI component related to overdiuresis, and they give her some IV fluids. And they ask for another ultrasound to kind of reassess where her venous congestion and volume status is at. Okay. So now we look at her hepatic vein. And this is sort of, I was on an extension of her thoracic vein, thoracic ultrasound. And when we got to her hepatic vein, putting Doppler on, and again, ECG gating would be very helpful here, but what we sort of felt that this is likely her S wave here, and this is likely her D wave here. And so what we're seeing is an S greater than D, which is normal in her situation. Looking at her portal vein, we actually see a nice continuous waveform, much better than what she had on the first VExUS scan and on the second VExUS scan. and our portal index or our pulsatility index is normalized here. We came back to subcostal area. And as you can see, our IVC is actually quite flat and very collapsible. If we started with this, we wouldn't have had to do the hepatic or portal, but I think it's a nice proof of concept here anyways. And ultimately, you know, she was a VExUS of grade 0 at this point. And so her creatinine actually did improve with the IV fluids. She was better at 247. And the team has since been able to start her on a stable diuretic dose afterwards. I think it's a great case, actually. It kind of shows some of the goods and bads of VExUS, right? Initially being shown sort of in the classic sense, it was a marker of venous congestion. The team decided to diurese her more for that. The second portal Doppler I thought was actually quite interesting because you could probably make an argument at that point that maybe she needed even more aggressive diuresis because her pulsatility index has gotten worse. Now, despite that, she actually went home on a higher dose of Lasix and came back probably with a pre-renal component of an AKI related to overdiuresis. And so I think that's an area where in this case, where looking at just that portal index alone may have been very misleading for the team. And finally, this is also a nice area to actually look at. Serial VExUS scores can be very fruitful in this situation. The patient who has a difficult physical examination, showing that she actually is now VExUS grade 0, you can be a little bit more confident about giving this patient some IV fluids if need be. Okay, so then what is the role of VExUS in cardiorenal syndrome? I think ultimately, you know, there's some pros and there's some cons in this regard, as well from my experience last month doing this, which is obviously very limited. So some of the pros, I think, you know, it can be used as a dynamic reflection of a volume status that correlates with congestion, particularly in patients that have a very difficult physical examination otherwise. And it's nice, it's another additional data point to evaluate response to diuretic therapy. So certainly some positives about using this tool. The cons, however, I think it's a tricky thing to do accurately compared to with maybe the cardiac or lung ultrasound. I think there's probably a good amount of inter-user variability in the way we do this study. There's a lot of patient limiting factors. For example, you know, patient size, being able to visualize their vessels, patients being able to hold their breaths appropriately. These are all such key factors in being able to get a good VExUS study. As you sort of pointed out, it can be misinterpreted in isolation. As with anything else, I think it really needs to be integrated with the whole clinical piece and all the other data points we get as well. There's no established guidance on how to use it. Like, should we be doing serial VExUSs on all our patients being decongested? So right now it's very much a who's comfortable with it and when they feel is the right time to actually utilize that study. And so because of that, there's sort of a lack of standardization looking at one case where VExUS is used to another. And finally, the last sort of point that Dr. Burhani and I sort of took some time talking about was, is this just sort of redundant information at some times? A lot of situations, a lot of the VExUS studies that we did over the block were sort of just that additional data point. But at that point, we already knew the patient had congestion based on their lung ultrasound, based on knowing that they had a bad EF. And so sure, we can see congestion on the VExUS study, but would that have changed much? Probably not. And as you diurese the patient, you know, ultimately the important things are clinical symptoms, and is, you know, urine output, weight, are those things good enough? And is then VExUS just sort of redundant information? So that's sort of what I wanted to talk about. I think for me personally, I'm going to continue to try to do more of these studies. It can be interesting. And I think in the right patient, it can have high utility. Those are sort of my take-home points at least. But I wanted to open up the floor now to certainly questions and any other discussion points that people might want to have.
Hamza, I was just gonna kind of chat about the redundant part of it. Like, I think
Mhm.
that for me, I think the redundancy is nice because you can do like a POCUS of the lungs and maybe they have B lines, maybe they have thick pleura and it doesn't quite line up and you're not really sure why. So having more data points, for me, it always helps. And like, I just think that if they have underlying lung disease, fibrosis with edema on top, then it's not, you can't just purely use the lung. So the more data points I have, I find it just puts everything together better for me. Um, and then I guess kind of along that same line is that we use that 2 centimeter cutoff for the IVC, but I tend to still like, even if they were 1.8, 1.9, because we know there's a lot of trouble measuring the IVC, that we can be off, that there's patient variability, that sometimes, depending on the patient's size, they may not have the same size as a, a small female versus a big male. So I go ahead and still do the rest of it just because if I'm on the cusp of thinking about that IVC, but the whole rest of the exam is floridly abnormal, then again, it's like, it's just another data point, more redundancy, more data points. And it just putting the whole thing together for me is just easier that way. So like if they're on the cusp for their IVC, I don't strictly just stop at 2. I think Ross is doing a study right now in the ICU trying to figure out like stop go with the what do you do with that whole like cutoff of 2 and how strict we have to be about that. But yeah, so I think there is redundancy, but it definitely helps. And then doing it over and over and over, you basically get, like if you're maybe not daily, but I think you showed like great cases there to show that it's really misleading just following the creatinine. And so having as much data as you possibly can, it just helps you. So yeah, I guess that would be my 2 points is like, I like the redundancy, but I also think like, don't just stop at the 2 centimeters, you're at 1.9 or something. Just, I would do the rest of the VExUS just at even sometimes out of practice and curiosity. And then if everything else is completely abnormal, again, just not trusting that IVC is one of those take home points is like, and then, doing it over time and you see improvement. That's the whole thing with POCUS, right? Is changes are probably better than stop points. So
Yeah, that's a great point, Mel. I actually really like what you said about the 2 centimeter cutoff. Yes, it's sort of what they use in the studies to establish the protocols, but you're right. If you have a patient where you're really worried about venous congestion and you're getting a measurement of 1.95 and there's no respiratory variation, like, yeah, you should probably go ahead and get it done. So that's a great point.
So those are awesome cases. I think that's like a great way to show where this is useful. You had some good cases there.
Thanks.
Hamza, excellent talk, man. I love the cases. I love the way you presented it. I love the reference to Harry Potter. So just just one point I wanted to make was I think people like, I've noticed the residents like overreact to the creatinine, and so I'm glad you kind of brought that up. That slide was like very informative. That don't overreact to things. Like right away, the creatinine goes up by 3 points, and you're like, oh my god, like have I made the wrong decision? And you come up with your assessment and you kind of stick with it. So I kind of liked how, I guess the creatinine went up to 400 or whatever. The team, with the help of the VExUS and clinical assessment and everything, said, well, no, I think we're on the right track. Let's just keep going here, right? And I'm sure they were looking at maybe patient weight. I don't know if they're looking at patient weight, urine output, negative balance, all those kinds of things. So it's putting those two and two together. So that was a really sort of cool slide. The other thing that I wanted to ask you was, in your literature, did you come across anything in your search about CKD patients and like their renal artery resistance indices and or their venous flow? Because I've always wondered, and this is sort of question for you and for anyone else on the chat who may have sort of looked into this. I haven't, but I always wondered, people that have underlying CKD, do they have elevated, do they have like altered flow patterns to begin with? I don't know if any of you guys know.
I to be honest, everybody, I have not come across that. I think for the studies, they excluded patients that were on dialysis.
Yeah.
But yeah, I'm not sure if anyone else has had some experience with that.
In the original VExUS derivation studies, they definitely excluded dialysis patients, even advanced CKD patients, as well as cirrhosis patients, as you mentioned. It's just with the idea that if there's underlying parenchymal or underlying end organ dysfunction, you are expected to have some kind of hemodynamic variation, but it's not well defined as far as I know.
Right. And I remember we ran into this issue a lot in the ICUs when we're doing VExUS in the ICUs. All these patients were on like, CRRT or whatever. And we're just having a hard time either picking up flow and or, like reliably sort of, looking at those parameters. But look, like most of the cases that you did, you just relied on hepatic vein and portal vein, flows. And obviously with people that have right side failure chronically or cirrhosis and stuff, you have to obviously, take that with a grain of salt as well. So, yeah.
Really good job, Hamza. I'll kind of put in my 2 cents. So I would say probably a month ago, I would have erred on the side of, yeah, the VExUS is redundant. I probably don't need it. I probably can use other factors to determine if someone's needs diuresis or not based on their thoracic and their cardiac scans. And after the last 2 weeks of running like a 35 team list with like no juniors or seniors, and actually having like probably a dozen patients admitted with like bad multifocal pneumonias who have heart failure, I've been doing this like every day. It adds 2 minutes to my assessment at the bedside. As you mentioned, you can incorporate it kind of into your thoracic scans. And in a couple of cases, I find it's the most useful when it's at its extremes, like anything. Like those patients where like, oh, wow, there's a lot more congestion than I thought, like clinically when I'm like looking at them. But they have a bad RV, that they're, they have a bit of an AKI, or they're severely hypoxic, and you're trying to determine how much of that is infectious, inflammatory, how much of that is volume overload, etc. And in a couple of cases where, you might actually be able to say, whoa, I need to like stop diuresis. This is not really congestion and heart failure. And I need to kind of go back to thinking about what else can be kind of contributing here. So I think for kind of a bang for buck to be able to just add it to your thoracic scans, so take an assessment that takes maybe 5 minutes and now let it take 7 or 8 minutes, it definitely informs my management pretty significantly. And I've done dozens of these over the last 2 weeks, and I'm like, yeah, I'm definitely going to keep doing it.
Awesome. Thanks for that, Mike.
Hi. Great talk, really great talk, and nice to see everybody so much into POCUS. And just a comment, yes, Melanie, what you said was very right, that more the parameters, we measure more the reproducibility, and a second person can, suppose one resident does it, and as a follow-up, another resident can come and reproduce because there are multiple parameters to study. That is one. Two, it's question to Hamza and of course to the teachers there, which is Michael and Dr. Yu. And I think I didn't know Zain is also doing so much of POCUS. So Zain, I don't know you personally, but glad to hear about you. How about when you all see so much of reversibility in hepatic vein and high pulsatility index in portal vein, do you always teach that go back and put a probe on the heart and make sure there is no TR? That is very important based on all the cases you presented. Because I have seen few residents who, as you said, jump into IVC and then make the decision because they are still not very heard about VExUS or not trained into VExUS. Then we do make mistakes based on that. But would you stress on the importance of always going back and putting a probe on heart and making sure there's no TR, or what is the heart function, RV and LV?
Yeah, I can take a shot at answering that, and then whoever wants to jump in. Thank you for your great comments. And to try to answer your question, yeah, I think that's a great point. It's like akin to the classic teaching of a patient coming in with an elevated JVP, and you give them a whopping dose of Lasix, and you find out later they have severe TR, and that's why. And it's just a similar concept here. And I think to your point, if you do see a really high VExUS grade score, I think our question for ourselves is like, what is the substrate that's causing that? So I think looking at the heart, then looking at the right ventricular function, looking for TR, all of those things are very important then. Right, same thing like a heart failure patient coming in. Well, fair enough, you want to give you Lasix, but why do you have the heart failure? So in that way, I think VExUS can also be nice. Like sometimes we pick up really bad congestion where we don't expect it. And then perhaps then we do a little bit of digging and we find that, oh, they have like septal flattening and they have RV pressure volume overload. And so I think that's a great point, and that's something we should probably emphasize a little bit more as well about what are the next steps. How do we like take these findings on our VExUS study and use them to inform us how we're going to use other parts of ultrasound as well.
I think one of the main foundations of how I want people to do POCUS is still to focus on the basics first. Start with the thoracic scan, do some basic cardiac scans, get some color Dopplers on the valves. And from that, you really can gain a lot of information on how to manage the patient. So like Hamza said, if on the basic cardiac ultrasound, you already see evidence of severe RV volume overload, septal flattening during diastole, it almost doesn't really matter at that point what the IVC or the VExUS or anything else shows, because we know that we have to offload that RV one way or another. We have to get the volume off one way or another. So in those instances, I personally would not recommend going forward to get the VExUS, for example, but I think in more complicated situations where you want more data points to try to integrate your results, I would say move on to the VExUS, add that on to your overall assessment. But I personally would not recommend starting with the VExUS. I personally would still go with the basic cardiac, basic lung, do some more advanced cardiac if you want to as well, and then maybe add the VExUS at the end to help you with your overall decision points.
Yeah, I think that was a great kind of response. I'll just add on a couple things. You definitely need to know your patient. So scan someone a week or two ago, severe S-wave reversal in the hepatic, by like phasic flow in the portal, and she had like small pleural effusions. I'm like, okay, I'm getting all gung-ho to diurese her, and then I'm, assessing her further, and then looking at my cue cards, and I was like, oh crap, cirrhosis, RV dysfunction, severe TR, none of those parameters other than, okay, the pleural effusions and the rest of my physical examination and assessment, none of those parameters are valid. And so, you take a step back and you say, okay, now I'm going to use all the other things that we've done up until now to assess this patient's volume status, and look for more ascites, look for other things that I'm going to do to manage her. And kind of a bit controversially, I'll say to Jeff, I had a patient who had severe flattening of the septum this week. Complete systolic and diastolic flattening throughout the entire cardiac cycle, RV volume and pressure overload. And we diuresed her on the first day, put out a ton of urine, and then she got a bit more confused and whatnot. We got a comprehensive echo the next day, and the RVSP was greater than 125. Look at the VExUS, no congestion. So I'm not going to diurese her any further, because even though there's complete flattening, and you could say there's RV volume and pressure overload, her RVSP is 125 and her left-sided pressures are like 110. So she's never not going to have that flattening there, which is just kind of that next step. There's not a lot of times where that added information helps. Not a lot of patients who have RVSPs above 120, but kind of going with what Mel said, any extra information that can push you one way or another is probably helpful, although maybe it's in the minority of cases where it's actually going to make that difference.
Yes, well said. And just answering to Zain's question regarding the resistivity index of renal, yes, they always go hand in hand, venous and arterial. The decreased arterial perfusion, then the venous also accordingly changes. So, and even in the VExUS diagram which he showed, Hamza showed, you could see the correlation between, as the arterial parameters change, venous parameters also change. So.
All right, maybe we'll call it there then, eh?
I just had a quick question, sorry.
Yep.
This is Monty, I'm from U of T. We're just sort of starting in the early stages of our POCUS program. So
Okay.
VExUS is really a bit further out from where we are. Is there literature to show that use of VExUS will reduce ICU transfers from internal medicine, or reduce needs for or reduce time to improving renal function in your diuresis patients?
From my review of the literature, no. So it hasn't really been, it's always been sort of like in a blinded study for the most part, where they're just trying to prove that there's a correlation at least between decongestion and what we're seeing on the VExUS. So to my understanding, they've been mostly proof of concept sort of studies. And I think the next steps would be to kind of put it in that clinical context. If you utilize VExUS, that actually lead to better outcomes for patients. And I know that I look very interesting to see what comes of that.
I'd be surprised if there was ever a study that showed that. I feel like it's the same as a study showing that like chest X-rays improve mortality. Diagnostic tests, like in this case, to me, VExUS is a continuation of the physical exam, continuation of diagnostic testing. And unless you are trained to interpret that study and then act on it, it's really hard to show that the use of something like VExUS would lead to improvements, I think. But I would love to see something like that. I'm not going to stop using it.
No, so far only nephrologists have been very keen in using it, but ICU has rarely used or studied VExUS. So maybe you can start that. Okay, nice meeting you all. Bye.
Thank you. Nice to meet you all too.
Thank
Thanks
you
a
very
lot,
much.
Hamza.
Great job,
That's
Hamza.
great.
Thanks everyone
Thanks,
for joining.
guys.
Thanks, Hamza.
No worries.